Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring advances in glaucoma and age-related macular disease. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare, education and research. Dr Helen Do is an ophthalmic surgeon at Macquarie University Hospital, specialising in medical retina and cataract surgery, with a focus on diabetic retinopathy and macular degeneration. Dr Aparna Raniga is a glaucoma and cataract specialist at Macquarie University Hospital, with expertise in advanced surgical management of glaucoma and complex cataracts. They join me now. Can you provide an overview of age-related macular degeneration and glaucoma and explain why early detection is so important?
So starting off with AMD, which is age-related macular degeneration, it is such an important condition, and it is the leading cause of irreversible vision loss in adults over 50 in developed countries. So really in Australia, it affects 1 in 7 adults over 50 years of age. That means lots of people will have people around them affected by macular degeneration or know of people. And that adds up to around 1.3 million people in Australia. As the population is aging, this becomes even more important. Age-related macular degeneration is often asymptomatic in its early stages, and so people don't realise that they have the disease. And and conventionally, there wasn't treatment available. It's irreversible. But now there are treatments available, with more treatments becoming available. So it's important to recognise the conditions earlier to identify these patients so that early intervention, including risk management and treatment, can be started to reduce the risk of devastating vision loss. And glaucoma also is an asymptomatic condition. So I'll let Aparna expand further on this.
Yes, so vision is everything. Vision is functional life. Without having good quality vision, we really would find it difficult to function and to be independent. And this is particularly important as one gets older. Basic things like looking after yourself, going out shopping, driving, socializing, going to restaurants, all of these things are events that we just take for granted in our everyday life. And as Helen mentioned, it's really important to prevent irreversible blindness by detecting these conditions when they are early, so that they can be managed appropriately to prevent functional blindness. So with glaucoma, just like with AMD, glaucoma is known as the silent thief of sight. There really are no symptoms. There is no pain. There's no visual loss. There's no red eye. The only way to detect glaucoma early is by having an assessment, a thorough glaucoma assessment done, whether that is with your local optometrist or whether that's more in depth with your ophthalmologist. Now, why is detecting glaucoma early so crucial? We have now excellent treatment strategies in place to delay the rate of progression of glaucoma. And by that, I mean, as a community, as a glaucoma community, we're moving away from drops with preservatives in there to maintain quality of life, to offer selective laser trabeculoplasty early, again, to control the disease as well as maintain quality of life, to offer cataract surgery in a timely fashion associated with early minimally invasive glaucoma procedures, again, tackling, maintaining pressure and therefore maintaining quality of life. And all of these things can really be done best when they are done in a proactive manner.
What are the main classifications of AMD and glaucoma?
So AMD is age-related macular degeneration. So the actual disease is really in the name. It's for people that are older, so you develop it above 50 years of age. and the risk increases as you get older. It affects the macula. So the macula is the central part of the retina that I've mentioned before, and that's the crucial part of your central vision. And it's a degenerative condition, so over time it gets worse. Most people just classify as wet and dry macular degeneration, so people often just find that division. But it actually, if you go into the formal classification, it is thought of as early disease, intermediate disease, and late age-related macular degeneration. And the late can then be also subdivided into wet and dry. So wet macular degeneration refers to new blood vessels coming through from the choroid, which is the blood vessel layer under the retina. And normally those vessels are not meant to enter the retina because there are tight junctions between the retinal pigment epithelium cells that keep the blood vessels away. But when these cells become damaged and diseased, these abnormal blood vessels can grow through and cause bleeding and fluid and can affect vision. But even if it is dry, it's you have to realize it's not that it's okay, because people with dry macular degeneration can have atrophy. So the cells become diseased and die over time, and then that can cause reduction of vision. So basically, in early and intermediate age-related macular degeneration, the main feature you see are what we call drusen. And drusen can be thought of as build-up of waste material under the retinal pigment epithelium, which is the outermost layer of the retina. And these can be small, these can be large, they can join together to become confluent. And when we think of those, the way that people become blind from macular degeneration, it's those two late stages, which is either wet macular degeneration causing the bleeding and the fluid, or the dry age-related macular degeneration causing geographic atrophy. So the cells are just very damaged. And before I let Aparna discuss the glaucoma classification, I'll just mention one special type, which is PCV, and that stands for polypoidal choroidal retinopathy, which is a disease of that choroid layer, the blood vessel layer. And I want to mention this because it's actually more common in Asian patients. So you may have patients that go, I don't have the typical age-related macular degeneration. I don't have drusen, but they're telling me I have macular degeneration. So there is a variant where you can develop special little dilatations called polyps. And fortunately, the treatment is quite similar in terms of injections, but it's important that every patient with macular degeneration are different, and the disease course can also be very different. So I'll let Aparna discuss, possibly the glaucoma classification can even be a bit more complex, but I'll let Aparna share that.
That's lovely, Helen. Even I'm revisiting AMD and things like that, so that's fantastic. So with glaucoma, it's nice to step back a little bit and think about it both in terms of ocular anatomy, and I'll explain further in a minute, and also think of it in a primary versus a secondary. So primary as in it happens just within the eye with no particular underlying causes versus secondary where it occurs as a sequelae of other underlying conditions. So starting off with the ocular classification of glaucoma, which is the open versus the closed. So when we're talking about open versus closed, we're speaking about the angle. And the angle is that anatomical structure which is between the root of the iris, the colored part of the eye, the cornea and the corneoscleral junction and the ciliary body. So that's what we're talking about when we speak about open versus closed. So an open angle glaucoma, that anatomical structure is wide open and allows the aqueous to flow where it's created from the ciliary body, flows through behind the iris, and then flows in front through the anterior segment into the drainage pathway, into that angle. In closed closed angle glaucoma, that anatomical structure is closed, and it's a physiological and anatomical barrier to the outflow of aqueous. And as a result, because there's that anatomical barrier, there is associated high pressure. High pressure can also occur in open angle glaucoma as well. And we'll talk about that in a minute. So the wide classifications, open versus closed, primary versus secondary. That's a useful way of assessing glaucoma. With the primary versus secondary, primary, again, it happens on its own idiopathically. Secondary, it's worthwhile considering other things like ocular features. So has this happened because a patient has got other issues, say uveitis, which is inflammation in the eye? Have they had retinal surgery where they've had silicone or oil or gas or whatever that's occluding the drainage pathway in the eye? Is it because of a really, really large cataract that has not been addressed? And those are the ocular secondary features. And then you've got systemic associations as well. So, for example, patients who are on particular kinds of medications which can block off that drainage pathway. Antidepressants, for example, come to mind very easily. There are also a number of other medications associated with it as well. And that's sort of an overall view of glaucoma, but it's really one of the most important things to remember with glaucoma is it's an umbrella term. So it is just literally describing that the optic nerve head is diseased. And so therefore, that impacts on the peripheral vision as well as central vision. And so hopefully that provides a very, overall assessment of what glaucoma is.
With the clinical features, what symptoms do these patients have and how do you diagnose these conditions?
So, with the clinical features, macular degeneration and glaucoma can both be asymptomatic. So, the most common way that these patients are picked up when I focus on macular degeneration is that it's picked up by routine screening by optometrists. So, patients will turn up to their optometrist and say, "Oh, I need glasses." And the optometrist now, with more technology, they'll be able to examine better with the fundus imaging and take photos of the back of the eyes, and they'll now pick up early changes, such as the drusen changes. From a general practitioner point of view, patients may come in and complain of just reduced vision. They might just say things are a little bit blurred than they used to be. Night vision's getting a little bit more difficult. And then you've got the other type of patients who will come in with a more acute presentation. So their vision has suddenly dropped. They've got a central blur. And the classic symptom that patients describe is the distortions. So I've got patients who will say, "I'm looking at the tiles on the wall and suddenly the lines look a little bit crooked or curved." And this is that classic symptom of metamorphopsia. And this is due to the disruption of the cells in the retina. And when we see these acute, subacute symptoms, then we're worried about the new vessels, the wet macular degeneration. So in terms of clinically for an ophthalmologist, when patients come in, we test their vision, and obviously we see how much the vision has gone down because of the macular degeneration. And often with early macular degeneration, they can read the chart absolutely fine. They have, 20/20 vision. As this progresses, then it goes below driving standards and potentially to the level of legal blindness. When we're examining patients, we look for, as we mentioned, drusen, other little changes in the retinal pigment epithelium, the atrophy, any bleeding, any neovascular membranes. And we can also take photos to document this. The cameras have become better and better, so we can now do what's called fundus autofluorescence, which helps to show how healthy the cells are. And probably, the one tool that I can't live without as a medical retina specialist is what we call OCT, which is optical coherence tomography. And this is basically a special equipment which uses reflection of light waves to image a cross-section of the retina and can actually show, micron details, including measurements, including the different layers, including new fluids. So it's really been very revolutionary in terms of medical retina imaging. And this really helps us distinguish between wet and that dry macular degeneration, because that's quite key to treatment. Before OCT, I'm going back a little while when, OCT was just starting to be included when I was earlier in my training. You'd have to examine patients and sit there going, oh, is it wet? Is there fluid? So now it's a lot more objective. There is also a test that we can do to have an understanding of the vasculature underneath, and that's called fluorescein angiography. And what that is we inject a special dye that inject through the veins of the arm. It goes through the retinal circulation and we take photos, and it gives us an idea of how the fluid leaks. This is probably becoming not as crucial as it used to be a few years back, and largely thanks to the OCT, but also there's now what we call OCT angiography, which is a non-invasive tool. Basically, the OCT is just one more scan, and it allows imaging of the blood flow through the retina and choroid, and that's been also helpful. So I'm not sure if Aparna is as much of a fan of OCT as I am, but it's very useful for glaucoma as well. So I'll let her discuss the clinical points for glaucoma.
That was really thorough. Thanks, Helen. The major issue with glaucoma is there are no symptoms. So I will get referred my patients who've seen either their optometrist or their ophthalmologist with, please review this patient with concerns of glaucoma. And my opening question to these patients is, how can I help? And they often sort of shrug and they say, I don't know. I don't actually know why I'm here. I can see perfectly fine. So it is not apparent to me why I need to be here. And that's exactly the issue with glaucoma, the silent thief of sight. Unless a patient has moderately advanced disease, which involves loss of fixation in the central seeing part of the eye, or they have lost at least 30 to 40% of their peripheral vision, they will have no symptoms. Now, remembering that glaucoma is irreversible, as in if they have lost vision, no matter how clever or aggressive the treatment is, it is not possible to recover what has been lost. The most important cornerstone of glaucoma management is proactive diagnosis. So as with AMD, we depend quite heavily on optical coherence tomography. There are now excellent computer programs which will analyze sequential optical coherence tomographies and assess whether there is progression over a period of time. So glaucoma, the hallmark of glaucoma is progression, because as I explained to patients, there is accelerated loss of retinal nerve fiber tissue on top of normal aging. So yes, we all, normal people included, lose retinal nerve fiber layer tissue as we get older. But the key point of difference with glaucoma is accelerated, not normal, abnormal loss of retinal nerve fiber tissue over time. And so these computer programs called guided progression analysis help us detect disease before it becomes a functional problem. Another test that's done by glaucoma specialists is what we call automated visual field testing, where patients will sit and have each eye tested separately for their peripheral vision. It's out of the scope of this podcast to discuss what a field test is like, but that is also really important to correlate the field test with this optical coherence tomography to assess whether glaucoma is, number one, whether it is a diagnosis of glaucoma or whether there's been any evidence of progression. And of course, a comprehensive glaucoma examination is examining the patient, going back to first principles of figuring out whether this is primary versus secondary, open versus closed. Are there any other underlying features? And glaucoma it may not necessarily be restricted to the eye. So it's not necessarily just an ocular condition. It can be associated with vascular risk factors, migraines, rhinos, other issues like that, obstructive sleep apnea, hypotension, low blood pressure from blood pressure medications that are taken at night, a history of significant blood loss causing hypovolemia. So there's a detailed history taking, understanding risk factors for glaucoma, understanding whether there's a family history of glaucoma. So it's quite a thorough and detailed assessment for that first specialist glaucoma assessment that goes into play when we're assessing for glaucoma.
How do you approach the treatment of AMD and glaucoma, and what new or emerging therapies are available?
Thanks very much, Sally. So I might start the discussion in talking about supplements first, because we are talking about a proactive approach, and so just about how we can reduce the risks. So there are supplements available for age-related macular degeneration, but interestingly, the pivotal study was done in 1992. So that was the ARID study, the age-related eye diseases study, which was a huge trial in the US run by the National Eye Institute, which included around 4,000 to 5,000 patients. And we pretty much still use what came out of that. This was further followed on by ARIDS 2, which was looking at those patients long term. That was in 2006. And basically, they came up with a combination of supplements. And together, it was shown to reduce the progression from intermediate to advanced age-related macular degeneration by 25%. So, that's quite a significant number. So a significant reduced risk of vision loss. And the initial supplement was vitamin C, vitamin E, zinc, copper, and beta-carotene. And the ARIDS 2 study, which was done in 2006, changed the beta-carotene over to lutein and zeaxanthine, and showed that it was around 18% more effective. So that's a supplement that we use now. And in terms of brand names, the ones that are on the market are MacuVision Plus, which is by Blackmores, and then the Australian company which runs Macutech, and there's also MDIs and a few other supplements as well that follow the same formula. So I want to discuss what treatment is available now to actually manage age-related macular degeneration. And the treatment now is for wet AMD, the neovascular age-related macular degeneration. And the main treatment is anti-VEGF, which stands for antivascular endothelial growth factor. And these are injections that go in the eye and reduce the drive of VEGF that can drive this process of the new vessels and the wet macular degeneration. So in terms of the medications that are currently available and being used, if we go via timeline, the one that's been probably used the longest specifically for AMD is ranibizumab, which is Lucentis. And then aflibercept, which is Eylea, was introduced to have a longer effect. Following that, Beovu brolucizumab was introduced. However, this had issues with vasculitis. So I don't think it had that uptake that they were hoping for, and we don't use this as much. About 2 years ago, we had the introduction of faricimab, which was the first agent that targeted two pathways. Instead of just VEGF, it also targets a different pathway called Ang2, also just aiming for that longer effect. And most recently, we now have Eylea, which was traditionally 2 milligrams, but 8 milligrams is now available. So a more concentrated form of Eylea. And really, the aim for all of this is to treat the disease and then reduce the burden of the disease. So what we do is when patients come to see us, and if they have dry age-related macular degeneration, we talk about supplements and risk reduction, which I'll go into later. But if they have wet AMD, then we offer them treatment with anti-VEGF injections. Every doctor can have a different preference, but my preference is usually to start with Eylea, 2 milligrams, and we start with 3 monthly injections. And after that, we look at the progress, and the aim is to extend the treatment. So we may extend by 1 week, 2 weeks, up to 4 weeks at any one time. And we try to extend this out till a maintenance level of around 14 to even 16, 18 weeks now. And we usually continue that maintenance injection until it's either very stable that, we talk about switching to a as required regime, or if the patients have very poor prognosis in that eye, if there's a lot of atrophy, we may consider stopping the treatment earlier. So when patients say, is this a lifelong treatment? We say, look, maybe not for the rest of your life, but definitely a long-term treatment.
What impact do you see when you treat patients?
What we see is when we treat patients with these injections, then the bleeding reduces, the fluid especially settles down, and we monitor this by measuring with sequential OCTs. The vision often improves, but in advanced cases where there's lots of scarring or damage, then it's not always to help recover vision, but to maintain the current level of vision. Because if untreated, then this can get to the point where there's very excessive scarring or bleeding. I've seen patients with bleeding, that spreads all throughout their retina and irreversible blindness. The other thing I just will touch on here, because I get this question a lot, is patients often ask, do injections hurt? Because the thought of having injections in your eye every 4 weeks, I don't think is pleasant to anyone. But to be honest, I tell patients that the majority of patients are not troubled by it at all. So what we do is it's actually 2 injections rather than 1. The first is an injection of local anesthetic just under the skin of the eye, the conjunctiva, and we leave that to have its effect or a few minutes. And when we actually do the injection into the eye, we enter a space that's very safe, that's not going to damage the lens and not going to damage the retina, which is around 3.5 to 4 millimeters just behind the edge of the cornea. And then we inject into the vitreous cavity. And the volumes that we inject are around 0.05 of a mil. So that's a very, very tiny amount. With the 8 milligram Eylea, it's a little bit more. We can inject up to 0.07. So really, the injections patients tolerate really well. Most patients come out saying, I didn't feel anything. We spend more time just putting lots of antiseptic on, or the clip that holds the eyelid open can be a little bit uncomfortable. But I guess if you have patients who are concerned, you can reassure them that most patients are very comfortable. The new exciting thing that's happening is, after years and years telling patients there is no treatment for dry age-related macular degeneration, and if you lose vision because of atrophy from this, there is now treatment available. So this has actually been available in the States for a few years now, but the TGA has only just approved this in January of this year. So this is really, breaking news. And the category of medications are complement inhibitors. So they found that this pathway is responsible for cell damage and cell death. So one medication, so pegcetacoplan, is now approved. It's TGA approved, but not PBS approved, which I'm sure the doctors listening will know means, yes, we can use it, but it would be very expensive to use. So we are looking out for the progress on this. I'm not sure if the companies will start offering samples once this pathway will be established so that we can offer it to our patients. And we hope this will benefit patients who have, geographic atrophy, which is progressing. So sometimes you watch this patch, it really is a well-defined patch of damage that seems to just be getting bigger. And then the minute it hits the center, the fovea, it's going to make the patient blind. Or they've lost vision in the other eye because of this. And these are the patients we hope to be able to treat with this new treatment. These will also be injections into the eye, but hopefully it will mean even patients who are losing vision from dry macular degeneration will now have a treatment option. And just finally, just other things that are in the pipeline that are being looked into. So there are agents where they're targeting different VEGF. There's also port delivery systems, and basically that's like a reservoir that's being implanted by surgery into the eye, and then you refill that reservoir so patients aren't having to come for injections every month. The other thing that's always being looked into are gene therapy and stem cell therapy. So that's still, much in the research phase, but really promising.
So moving on to glaucoma. Glaucoma used to be all about drops. Drops and more drops and more drops until the drops didn't work or the glaucoma progressed, and then patients were offered surgery. Surgery which carried risks that were fairly significant. Probably in the last 12 years or so, things have changed. The change was brought about by the advent of guided progression analysis, which is a computer program assessing OCT scans, scanning getting better, patients being more proactive in presenting for assessment earlier. And so as a result, as these early predictive diagnostic assessment tools improved, we were able to address treatment for glaucoma better. So there's sort of a four-pronged approach in terms of treatment for glaucoma. The first is, again, the cornerstone of treatment is a stitch in time saves 9, so early detection, that's number 1. Number 2 is treatment so that you treat the disease but also manage quality of life. Number 3 is if there is any evidence of progression, as in the glaucoma is deteriorating, then treating it aggressively. And number 4, if a patient is unfortunate enough to present with late disease, then aggressive treatment is indicated and supported by multicenter large trials. 2 of these trials actually, which have been replicated about 25 years apart. So going back to dissect these 4 cornerstones or 4 pillars of glaucoma management. Early detection, we've gone through that in a fair amount of detail earlier. The second cornerstone is treating so that pressure is well controlled, but without sacrificing quality of life. And by that, I mean, yes, offering patients treatment in the form of drops, but moving towards preservative-free drops rather than stacking up on a lot of glaucoma medications that disturb the ocular surface and cause a lot of side effects. Glaucoma medications have essentially 4 treatment characteristics. I won't go through the details here and bore you, but they all come with side effects. So essentially you're taking a patient who has a reasonably good ocular surface and I'm prescribing them medications which will disturb that ocular surface. So if I'm able to offer them a treatment which doesn't cost them a good quality of life in terms of degrading their quality of vision because of the ocular surface disease, making their eye red, uncomfortable, giving them a bitter metallic taste in their mouth as a result of one of their glaucoma medications, affecting their bradycardia or exacerbating their asthma, for example. That's really, really important. So minimizing side effects, maximizing efficacy, and really not tolerating side effects with glaucoma medications as we used to in the past. So patients coming in with red eyes, we tend not to tolerate that quite as much as we used to when, for example, when I was a registrar. So as a result, using preservative-free glaucoma medications, essentially there's about 4 of them, prostaglandin analogs in the form of Xalatan preservative-free, Lumigan preservative-free, combination treatment, which is Ganfort, which is Timolol, and Bimatoprost, which is Lumigan. That's another one that's preservative-free, and Viso, which is a combination of a beta blocker and a carbonic anhydrase inhibitor. Essentially, we have 4 options, and as a glaucoma community, we're moving towards using those initially first. That and one other aspect of treatment has also changed, and that is using selective laser trabeculoplasty, or SLT for short, using that earlier in the glaucoma treatment paradigm rather than using it as a last Hail Mary, bridging between using stacks of medication and then considering surgery. So that really came about because of a pivotal trial called the LIGHT study. Wow, what a fantastic name they came up with. So LIGHT study is short for selective laser trabeculoplasty versus eye drops for first-line treatment of ocular hypertension and glaucoma, the LIGHT study. So that initially was published in 2019 in The Lancet, and it looked at 718 participants across 5 sites, multi-center study in a number of countries. And the primary outcome was looking at quality of life, but of course also treating the pressure and making sure that was appropriate. So using selective laser trabeculoplasty applied as an office visit to the drainage pathway instead of doing daily glaucoma drops. Their primary outcome was that they found no significant difference between the two groups. So they randomized them 50-50 to either laser or receiving drops. And the primary outcome, which was reached, was there was no significant difference between the two groups. They also achieved secondary outcomes as well, which is that 97% of SLT patients that were treated first line were more cost effective than doing drops, 97%. 74%, so 3/4 in the laser group, required no drops to maintain their intraocular pressure at target. And they found that the patients in the laser group actually had a much better quality of life than those patients who were treated with drops. So this has sort of revolutionized the treatment of glaucoma, and it's only just sort of starting to come through now, because in 2020, the NICE guidelines, which is the National Institute for Health and Clinical Care Excellence, in the UK has endorsed the use of SLT as first-line treatment for both ocular hypertension, as in high pressure without the evidence of glaucoma, and also in patients who have been diagnosed with early glaucoma. So early open-angle glaucoma as well as ocular hypertension, SLT is now first-line treatment as endorsed by the NICE guidelines in the UK. So what that then does is, because glaucoma is being treated proactively, it then reduces the rate of progression of glaucoma, which then means that the need for further incisional surgery, which carries risks, is diminished. And we know now that by proactively treating glaucoma, that has actually come true. The rates of needing incisional or advanced glaucoma surgery has fallen since the use of preservative-free drops, since the increased use of laser. The rates of trabeculectomy, not just in Australia but worldwide, have dropped, and they have continued to drop over the last 7 to 8 years. So that is that summary was looking at those with early glaucoma. One other landmark study which is worthwhile mentioning is the EAGLE trial. I think ophthalmology has amazing names, just like cardiology. We might have even stolen from cardiology back in the day with coming up with these awesome names for trials. So the EAGLE study is looked at the effectiveness of early lens extraction for the treatment of primary angle closure glaucoma. And that enrolled 419 participants from 30 hospital departments in 5 countries. And they had 419 participants, and they looked at patients who had angle closure, randomized them to either preventative laser or to clear lens extraction. And they found that those patients who had early lens extraction in this particular group, they found that those patients randomized to early lens extraction had much better sustained intraocular pressure control. They also had much better quality of life, and the need for further glaucoma surgery was significantly less in those patients who underwent early lens extraction instead of those who had preventative laser to treat angle closure. Now, this is not really a surprise, to be honest, because the preventative laser was not directly addressing the underlying cause. By removing the bulk of the cataract, that actually helps the angular anatomy. And so it's not really surprising why the results have, panned out the way they have. So our rates in the glaucoma community of using peripheral iridotomy to prevent these episodes of angle closure have, as a result, also dropped off. And then moving on to other forms of early procedural intervention, the cataract surgery plus microinvasive glaucoma surgery space has absolutely exploded in the last 10 to 12 years, so much so that the rates of trabeculectomy have fallen, as I alluded to before. So cataract surgery occurs in patients as we get older. As I explained to patients, nearly everybody is going to get a cataract if they live long enough. Yes, it is symptomatic. The cataract can be symptomatic at different ages in different patients, but really, if they have concurrent glaucoma as well, then cataract surgery is the first glaucoma surgery they have. And so addressing the cataract and then addressing pressure control at the same time really makes complete sense. And so that started off with eye stents, which were FDA approved in approximately 2010, I believe. They have been TGA approved in Australia for over a decade now, and there are newer iterations of these stents available. Eye stents are not the only microinvasive glaucoma surgery. There are also a number of other stents that you will hear of. They are Hydrus microstent. There is also a new kid on the block called MiniJect, which is a suprachoroidal device which has just received TGA approval. There are other angle-based procedures which do a variety of things, deroofing the angle, dilating the canal of Schlemm, either externally or internally, but these are generally all done in combination with cataract surgery. So devices have become really big in the glaucoma community space. But moving on to those patients who present with glaucoma a little bit later, where they've lost a lot of functional vision, what do we do with patients like that who walk in and they've lost a lot of vision? So in those patients, it really does not make sense to wait, stat medications, see how they go, possibly offer some laser treatment 6, 8, 9 months down the track, and then consider surgery if they're still progressing. They've already lost a lot of vision. And so the TAG study, which looked at treatment of advanced glaucoma study, TAGs, found that those patients who presented late with their disease did much better with glaucoma surgery that was offered quickly, rather than sort of wasting time with drops and then laser and then considering surgery later. So that's where we are from the treatment approach. Now, coming on to supplements. Supplements are not so big in glaucoma. Vitamin B3 has been investigated in the past and found to be useful. There is a current study enrolling patients through the Centre for Eye Research in Melbourne in Australia, which is looking to see at what concentration and daily administration dose of vitamin B3 is useful in terms of preventing progression in glaucoma. So that's a watch this space. Other supplements that have been considered in the past are ginkgo biloba as well. Again, the results are not conclusive. Some other more alternative treatment strategies are considering exercise. Again, mouse models have been looked at and have found that exercising on a regular basis reduces the amount of oxidative stress and therefore can be useful in glaucoma. Hasn't been confirmed in patients. And then a really alternative and out there treatment strategy is considering meditation in reducing the amount of free radicals being present. So in addition to meditation, deep breathing. Now that study has also not been replicated. So supplements and these sort of alternative treatment strategies may not be a bad idea, but the conclusive evidence is lacking. other things that are actually useful in glaucoma, however, alternative treatment strategies, is asking whether patients play musical instruments, particularly wind instruments. Now, if a patient has established glaucoma and their glaucoma is getting worse, then I encourage them to find an alternative musical instrument to play or reducing their hours. Swimming goggles, I generally now encourage them to avoid wearing the tight Speedo, it's sort of Olympic swimming goggles, and consider more of the snorkeling type masks that fit around the orbital bones rather than increase the intraocular pressure with the Speedo type goggles. And that's sort of a good roundup on patient management in glaucoma.
Thank you to my special guests, Dr Helen Do and Dr Aparna Raniga. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare education and research. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.